This is DC EKG, exploring the intersection of politics and healthcare by diagnosing Washington and prescribing solutions. We take a deep dive into the legislation, regulation, and innovation impacting policymakers, providers, and patients. Now, America's health policy expert, Joe Grogan.
Welcome back to DC EKG, the most informative healthcare podcast that focuses on Washington, D.C. policy issues. I'm Joe Grogan, the host, and today we're joined by Jackson Hammond. Jackson is one of these young Turks who get on my nerves and reminds me how old I am every time I talk to him. And he clearly has a high energy level. So Jackson, thanks so much for joining.
Of course, Joe. Thanks for having me on. Look, you're doing better than me in the hair department, at least.
So let's talk a little bit about your role. You're a big shot at Paragon Health Institute, the most important new think tank in Washington, D.C. In healthcare policy, I'd say Paragon is now the most important think tank. And as far as number of references or impact, I think 2025 had a huge impact, bigger than anybody else's. And coincidentally, I happen to be chairman of the board and only got to know you for the past few years. So Jackson, let's start with you. How did you get involved in healthcare policy?
Well, I started 2017. I wanted to do trade and criminal justice when I became a young Senate legislative correspondent, junior staffer there. And I got assigned to the healthcare portfolio. And I got mentored there, though, by a great woman named Jamie Light, who's no longer with Todd, but she was Todd Young's longtime healthcare advisor. Between that and the mentorship, as well as it was right around the time, 2017, repeal and replace was big action. Everything was happening all at once. And healthcare was a really cool topic to be in. And I got to meet with a lot of people as well, patient groups, providers, et cetera. And you really learn how much healthcare matters in a way to people that tax policy doesn't. Not to attack tax policy or anything, it's very difficult. But my tax policy friends will point out when I go, man, I could never do tax policy. It's so hard. They're like, no one cries on you in tax policy meetings. And so it means something. And it really kind of imbued me with this sense of like, this is something that really matters to people a whole lot in a way that I hadn't considered before. I know healthcare is important. Doing that, I kept trying to get deeper and deeper into the policy. I went to the House for a year. I went to the Republican Governors Association as a policy advisor in healthcare during the pandemic, which was an incredible time to do healthcare policy in the States, by the way. March 25th, 2020 was when I started.
Right.
And then after a year there, I joined Think Tank Land, an American Action Forum. I was there for just under 3 years doing healthcare policy all the time. Then and I have to give them a shout out, the Health Reformers Academy, which is headed by Josh Archambault, formerly of Cicero. It was a great group of folks who I met there along the way, including El Nalmanarik, Tanner Aliff. But through that, I got connected to Paragon and I got noticed. And Brian approached me and was like, "Hey, we'd like to, bring you on." And I was like, "Absolutely. This is where all the magic's happening right now."
Cool. So, and in healthcare, what healthcare policy, what topics are you focused on most, or do you care about most passionately?
Right now at Paragon, my big focus is Medicare drug pricing. I think in those encompass a lot of the healthcare system,
Sure.
Spending over $1 trillion every year on healthcare, and we'll get into that later, on Medicare specifically, rather. Hospital reform policy in general really gets me going. I have found over the years, there's no good guys in healthcare. I'll put it that way. I think everyone has their problems as part of this sector. But for me, it's the hospital industry where you're not the doctor, you're not making the medicine. Somehow you're getting most of the money. It never ever sat right with me. And you've got, nonprofit institutions acting like for-profit actors, and they're, chasing after indigent patients with debt collectors who would otherwise qualify for their charity care programs, but they're hidden from that. There's just a lot of things in that really gas me up as well. I don't want to get too into it, but on top of that, kind of part of drug pricing, PBM issues as well. I got into that because my old boss at American Action Forum, Laura Hobbs, steered me down that road. And what used to be a thing I would avoid all the time, drug pricing in general, PBMs as well, was something I got really into. And it's now one of the things I've known for writing about. And of course, 340B.
340B, yeah, the gift that keeps on giving. It's interesting you said, I don't know any young conservative policy person who goes to DC to do healthcare policy. They all end up wanting to do something else, and then they kind of fall into healthcare for whatever reason, and then they find themselves intellectually intrigued, having the ability to run a portfolio that others are not interested in, and then you can have an impact. So it's not an unfamiliar story to encounter somebody smart like yourself who's more interested in other subjects on the right, and then realizes how cool it is. So what National Health Expenditures report came out in, I want to say this summer, June, correct? June, July timeframe.
Correct. Yeah, June.
You did a lot of digging into this. Well, first of all, what is the NHE report? What does it tell us about the state of the country?
It's not good. It's never good. I've never seen one of these that has ever been a good news. We are always increasingly spending hundreds of billions more every year. In 2024, the estimate is $5.2 trillion. Estimated for 2025, $5.6 trillion. We've grown in a year $400 billion extra spending on healthcare.
That's dollars shifting from one hand to another. So that encompasses Medicare, Medicaid, commercial, private pay, but everything.
Oh yeah, that's everything from business to business stuff between insurers and PBMs and other TPAs. All the government spending you could possibly imagine, everyone's personal expenditures, all of that's included in there.
So we're spending 5.2. We're projected to spend 5.6.
5.2. Yeah, 5.6 this year at the end of 2025. It gets up to $8.6 trillion by 2033. 8.6 trillion.
Which is like tomorrow. 2033 is like tomorrow.
I keep blinking and all of a sudden we're at the next crisis level for the Medicare Trust Fund or for the next spending cliff. All of this. And it is right around the corner. Everyone, it's hard to overstate how much of a burden this is. That is, in 2033, that will be over 20% of GDP for the U.S. Currently, we're already at a little over 18% right now. In 2023, it was 17.6%.
Right.
It is escalating constantly.
But here's the thing, and this is a little bit of a provocative statement, but who cares, honestly? I mean, if American people are rich and they want to spend money on health, why not let them spend money on healthcare as opposed to video games or as opposed to amusement parks or movies? What do I care if my neighbor is going to get, I don't know if plastic surgery is included. I would imagine plastic surgery is included in the National Health. Yeah, it is. So if they want to go get their eyes done or something else, or they want to go to the physician to have something looked at, what do I care?
I think it's not necessarily a question of like, should people be doing X amount? If they're voluntarily getting procedures, if they're willing to spend extra money on, premium care or some sort of concierge health service, I don't think that's the problem. The issue is that for the vast majority of people, these are not like, oh, I feel like spending more on healthcare today. The amount we're spending every year is a direct sign that people more and more are spending more of their money on healthcare, what they would almost assuredly rather spend on other things: rent, mortgage, their kids, any sort of various mundane or fun luxury item, anything else. I think very few people go, oh, goody, I get to pay a hospital bill. And these expenditures are also signs, not just that people are spending more, but the reason they're spending more is because prices are going up constantly. Premiums go up for insurance, prices go up for hospital care, prices are going up for at least out-of-pocket prices. Now we can get to that on the drug pricing side, but out-of-pocket prices are going up for drugs for the vast majority of people. And so we're seeing people spending more money where they otherwise would almost assuredly allocate it to something else if they had the option.
That's fair enough. Yeah, I don't think people are, as a general rule, would like spending as much as they want, and we're not getting any healthier, right, with all these expenditures.
Oh, no, no, no.
So
We are getting sicker by the day.
yeah. So what is what when you peer behind the numbers, and the top line numbers are pretty horrific? What does it tell you about the payer mix? Are more people accessing care through Medicaid, for instance, than they were 5 years ago? Are there fewer people covered by commercial? Where is all this money going? I mean, we hear a lot about drug companies are sucking up all this cash, but who's getting the bulk of the money? And when you look at it, Jackson, what are you drawing out of this data?
A lot of it is coming from growth, what we're seeing in Medicare expenditures. I think the part of the issue that some of this is a little intractable is that we just have a constantly growing Medicare population. We are probably at peak boomer entry into Medicare, but the issue is that the boomers also had kids roughly at or above replacement level of the population. So it's not like it's going down. There's not like a bubble that came and then it's going to go back down to like pre-boomer levels in Medicare. We're just going to see it kind of stay at that, if not grow slightly every year from there. I think that's probably the biggest issue. You're seeing, for example, the per-enrollee spending. So private health insurance is the majority of the spending. It's 1.7, or the plurality of the spending, 1.7 trillion in 2025.
When you say private health insurance, you're talking about me through my employer, you through your employer,
ACA, any plan that you're paying for a premium out of pocket that is not Medicare, Medicare Advantage, or Medicaid. That includes the government healthcare benefits as well. So if you're in does not count for TRICARE or the VA, but it does include, like, if you're in a union or if you're a public employee for a state or something like that, that counts as private insurance, which is questionable if that should really count as private insurance because that's so heavily subsidized by the taxpayer.
Well, yeah, we'll give it to them. Okay, so your number one trend line, your number one takeaway is the increase in expenditure just for the cost of private insurance. Is that fair or no?
I think it's the increase per enrollee in Medicare Medicaid, frankly, has significantly gone up. So in which it really shouldn't in Medicaid, you're getting technically a healthier population with the expansion. So it doesn't make a ton of sense that it's going up, but we can get into that. So for example, in 2022, private health insurance per enrollee spending $6,400, a little over that. 2025, it's $8,100 per enrollee. In Medicaid, it was in 2022 $8,800. Now it's almost $12,000 per enrollee. It's $11,900, and that's a pretty sizable chunk of an increase there, which you wouldn't expect to see again with the expansion population, which is supposed to be younger. These are able-bodied adults, typically without dependents. That should be, on average, decreasing expenditures. Questions about how that's happening, I think there's a lot of that could be involved with, as Paragon has pointed out a lot before, you have these things called provider taxes, intergovernmental transfers. The quick and dirty version of that is essentially the state puts a tax on its hospitals. The hospitals pay that tax, but then the state takes all that tax money, sends it back to the hospitals in Medicaid spending. But that, because it's Medicaid spending, the federal government then matches that money. And states have gotten really good at maxing that out. We officially banned this in the OBBB. We didn't ban the full practice. It had gotten all the way up to like states where the provider tax rate was 6%. States had maxed that out. We have now capped it in OBBB, if I recall correctly, about 3.5% now, which was what it was before a lot of regulatory changes made during the Biden administration. They let Medicaid approach commercial rates, for example, which has also increased a lot of spending. So I think that's a big portion of that as well. But with the One Big Beautiful Bill, or the Working Families Tax Cut Act, or whatever we're calling it now, reconciliation, we've cut out a lot of those practices. Now, in Medicare, we're seeing percentage-wise not as big an increase, and it's not totally surprising, again, given the cost increases in healthcare, but they went from in 2022 to $14,900 to in 2025, 17,600 per person. It's probably about what it's going to be, what you might expect given the relative price increases across the board for services, but as well as the general growth in the Medicare population. It's not great. We're spending 1.2 trillion. Yeah, 1.2 trillion in 2025 on Medicare. That's now normal. This has gotten to the point where I once saw there was some bill was going to save. Oh, this policy change would save. It was like $580 billion over the long term. I was like, oh, wow, that's a lot of money. And then over 10 years, if we held Medicare expenditures constant from here on out, that is less than 5% of savings over 10 years. We're at the point where $580 billion is now 5% in savings. And it's very difficult to wrap my head around that. And that is if we held it constant.
That's over a 10-year. It's over a
10-year period, assuming we held that constant from what we currently spend, the 1.2 trillion annually that we spend.
Right.
In 2033, CMS, who does the National Health Expenditures report, I might add, they're the ones, the actuaries there take all the data, they compile it together. It's typically published in readable format in Health Affairs, but you can go on CMS's website and parse through the data yourself. They expect by 2033 that Medicare will be spending $2.1 trillion in 1 year. It's mind-boggling. It is, and the reason this matters so much, it's not just, it's a large number, spending's going to grow as population grows, services prices go up, et cetera, inflation, yada, yada. The problem is that we are breaking the back of America's fiscal stability. We are often, it feels like a lot of times in fiscal conversations that are like, oh, can you believe this $3 million boondoggle? Or maybe it's $100 million even, which is kind of another problem itself, that the numbers have gotten so big that $100 million doesn't even seem like anything anymore. But you got a $100 million boondoggle with researching how lab rats react to jazz and cocaine or something like that. But that's small ball compared to our three biggest debt drivers: Medicare, Social Security, interest on the debt, and Medicaid is rapidly coming up on that.
Well, this is the interesting part. So on Medicaid, those numbers are really high. The growth trajectory is sort of crazy. Your point about the expansion population being healthier makes sense, but of course the expansion population is more expensive. But it doesn't matter, right? It doesn't matter that it's more expensive for the federal government because this combines both state and federal expenditures. So that's not really relevant. The match rate for federal to state. So why would these people be more expensive, including more expensive than private insurance? I don't think there's any Medicaid customers out there who are saying, ooh, my Medicaid coverage is awesome. I have access to all the physicians I want.
Right.
It's really good. And if given the opportunity to get private insurance, I would say no, because Medicaid is wonderful, right? And now here Medicaid is more expensive than private insurance.
Right. Per person. Yes. And I think so. Some of that is the per enrollee bit is in Medicaid. You do have the expansion population, but you also have, and the vast majority, I think it's somewhere around 80% of Medicaid's expenditures are on roughly 20% of its population, which is the disabled population. So you have folks with very severe disabilities who are on Medicaid. It's just expensive to care for them. And there's probably some reform you could do to try to keep prices down, but there comes a point where we stop talking about a fiscal situation, start talking about a value situation. I think the vast majority of Americans do not have a problem with, and in fact would like to have a safety net for the disabled, particularly, or as well as the low-income elderly are also on dual eligible for Medicaid, as well as for kids. I think that might be one of the things I learned in the big Medicaid fight with reconciliation was that Medicaid, in particular traditional Medicaid population, went from in the last, I'll call it the 15 years. In your wisdom, Joe, you might say it's been longer, but They went from a punching bag of sorts of this, like, well, this is just like, not that anyone was beating up on disabled folks, but the Medicaid population went from a punching bag to now it's almost as untouchable as Medicare. And I think there's a growth in disability rates as well. There's chronic disabilities chronic conditions are definitely up that are disabling people. I can't speak to how much that's contributed to it as well. But we now have, separate from that traditional population, we've got the disabled folks who, again, very expensive to care for, but I don't think anyone's going to say, well, those are where we need to make the cuts. It's the expansion enrollees, and they're also paid at a much higher rate for the match rate. So it's not just that the expansion enrollees, and we're looking at, it's not just simply that these expansion enrollees are expensive. They're typically a little sicker than the private population. It's kind of tracks generally with low income individuals, generally less healthy than folks with higher income. Again, having insurance, these things are correlated pretty well with health, but again, correlated, not caused by. Insurance doesn't give you better health, but having more money probably means there's a lot of other things going well in your life as well. Anyway,
right.
Aside from that, I don't want to we can get into the social determinants of health commentary, but
wait, so this is an important point that you're making, because there's a couple things going on. Clearly, there is a correlation between ill health and poverty. Some people end up in poverty due to illness. They lose their jobs. It's expensive. Some people, the expenditures for their health is so high that gives them very little income to spend on other things, as you referenced. But the existence of insurance coverage is not necessarily an indicator of being healthy, staying healthy, or getting healthy.
Correct. It is actually, Paragon has published a paper last year, I think, What Matters for Health, and talks about specifically in that there's a series that we're working on, but that was the first one that came out, and it was how much does insurance coverage actually play into making an individual healthier? What we found is that genetic factors and personal behaviors were far more predictive of health outcomes than any type of insurance coverage was. And it's whether or not you have simply being covered. One, insurance is not access to care. Health coverage is not health care. And so that's one, not inherently having a plastic insurance card, as I think a lot of folks with ACA coverage can tell you, or Medicaid coverage as well, frankly, does not mean a doctor is going to see you or that you can afford that doctor's visit. Additionally, there's personal behavior and lifestyle choices, whether or not you smoke, obesity levels, additionally, genetic factors, family history of heart disease, things like that, far more influential on your health than having insurance is. And I think we lose that so much in this debate where you've got, you can't go a day, and we definitely not over the summer, where if we passed OBBB 50, there was one estimate which people backed off of after it was proven to be ridiculous. One estimate, 50,000 people were going to die because and these were individuals who were almost assuredly able-bodied adults without dependents who were at risk of losing their insurance, their Medicaid coverage because of either work requirements or they got filtered out post-COVID policy. And so they finally felt like the government was like, all right, you have to meet certain requirements here. You're no longer in this income bracket. You were on Medicaid for too long, yada, yada. They predicted 50,000 excess deaths because of Medicaid coverage, which is not good coverage in the first place. That is deeply unlikely. Paragon has written about how that number, the death number total, is very flawed and looks at some very bad and poorly done research with typically observational studies.
So when you think about the misconceptions, when you're watching the news, what misconception that the media reports on gets you most angry? Or say you're sitting around at Thanksgiving and you're talking to your family and they have a misconception about healthcare that you're constantly having to correct.
Yeah, and it's not what I would call like a specific healthcare fact. It's the idea that conservatives don't care about people having health coverage. And this comes up repeatedly. It is always framed as oh, the Democrats want to give you health coverage and the conservatives, the Republicans want to take it away. Always. And we consider ourselves to always be on the losing end of that. We're bad at explaining why we feel a certain way or anything like that. But I think anecdote that illustrates this, that I actually caused a minor tiff. My girlfriend is a liberal. She used to work in a Democratic congressional office. Obviously, we have lots of liberal friends. She was talking with one of her old congressional colleagues at one point and came up like, oh, my boyfriend does this. He works in healthcare and healthcare think tank. And the question she got asked was, well, is he for or against healthcare? Meaning trying to figure out if I'm like in the lib parlance, is he a Republican or not? Is he a conservative? And I just hate that misconception so much. This quote is not original to me, but I find it to be the guiding light for what conservatives need to make the argument for is we want healthcare to be so cheap that you shouldn't need insurance for the vast majority of services. 95%. That's right. That's the conservative vision for healthcare. It is not you don't get healthcare. The Democrat vision is we want to give you health coverage. And then let's hope that healthcare comes out of that.
Right.
Or I won't say the Democrat vision, I'll say the left vision is we'll hope healthcare comes out of that. The right's vision is we want healthcare to be so cheap you don't need insurance for it.
Right. Right. As it is with so many other things. And this equation of insurance with healthcare access, I think, is another, or with health, I'd say, that just because you have coverage doesn't mean either A, you have access to doctors, or B, that you're going to get healthier either. So the increase in physician and hospital payments, any theories as to what's driving that?
Some of it is built up over the standard analysis is that a lot of there's a dip in demand for healthcare services in 2020 and 2021. And
during COVID, people weren't going to get colonoscopy screenings.
Yeah, exactly. And so you're still, and it's coming down a bit. It's projected to go down, well, at least the growth rate's projected to go down, I should say. We grew by about 8.2%, in 2024. It's expected to only grow like 7 and change percent in 2025. We're starting to hit the peak of all right, the things that were caused by you not going to the doctor, you not getting a colonoscopy, mammogram, for example. So like cancers that didn't get caught, other diseases or chronic diseases that were pushed off and dealing with or got worse over time. That bill eventually comes due, and it's been coming due the past 3 years. We seem, maybe, knock on wood, to be getting to the point where that is either you got treatment or much more morbidly people have passed on, depending on the severity of that disease. But that means that services and payments have gone up for doctors and hospitals. Also, on top of that, we've seen pretty rapid consolidation in the market for providers. These are long-term systemic factors involved in this, but health systems have been buying up more and more providers. We now have a majority of physicians are no longer independent, but they are employed by some sort of health system. So maybe that's owned by a hospital, maybe it's owned by a private equity, maybe it's owned by a PBM or an insurer. Everyone seems to want to get their own doctors these days. That has driven up prices with that consolidation. You no longer have enough competition, or rather you're losing competition that was keeping prices somewhat under control. It's not an intractable problem. There are a couple of pretty distinct policy reasons for this. Site-neutral payments, or rather site-specific payments, because site-neutral payments would be the reform to that. But the idea that hospitals get a tacked-on facility fee on top of whenever they have a physician in their employ care for somebody that an independent physician does not get, which means the hospital can afford to pay their physicians more so they can and they are also incentivized to buy up other physicians' offices. So not only they're attracting more talent, they're also buying up the talent that's not coming to them. So your consolidation there, you've got most markets, if I recall correctly, have less than 2 hospitals to choose from. It's particularly bad in urban and rural areas as well, where this And some of this, the hospitals will argue, and particularly in the rural areas, that, well, this consolidation was necessary to keep these hospitals open. This is a hot take, Joe, and I am speaking on my own behalf. I'm not speaking for Paragon here. There are a lot of these areas would do just as well if they had an outpatient care center and an emergency department, and not an entire hospital that the county, the state, and the federal government needs to keep dumping money into that is limping along. It's not really providing the services people need. And we know it's not providing this, or at least not to the quality that they're demanding. And we know this because 2/3 of individuals in rural counties choose to go to urban systems, even when we're comparing hospitals of what are called type 1 services, which, as I understand it, is the basic elements of what is required to be a hospital. You have to offer these services there, these inpatient services, essentially, or your standard inpatient services. So it's not like they're going for very rare neurosurgeries or something like that only like a couple of hospitals do. These are basic hospital services. 2/3 of rural residents choose to go to the urban system. They don't want to go to the county hospital. So we already see it's not meeting their needs because the market is moving, even when there's a concentrated market in their area. There's a hospital nearby, that hospital's not meeting those needs. It would be, both for the patients as well as the taxpayer, be a lot cheaper. And there's a little bit of there is a government program that kind of does this. I hope to see it get used more and more frequently as time goes on. It's called the Rural Emergency Health Program, the REH, Rural Emergency Hospital Program, rather. It allows hospitals to downgrade. You get a bump in your Medicare payments a little bit, but you take out almost all of your inpatient beds. And so you'll functionally become an outpatient clinic with an emergency department. And that allows resources to be used for other hospitals, in particular when most people are going to those places anyway. That's what the vast majority of people generally need.
Interesting.
You need the emergency department, of course, and the outpatient clinic is good to have nearby people. You don't want someone driving 2 hours to get a colonoscopy. It's not ideal. They're probably not going to do that. No one wants to sit for that long after colonoscopy. But we probably need to rethink on the hospital reform front. And you don't want to force this. Barring some sort of like 1990s military base commission that what Congress had for that, where they like got in a secret room and decided to close down bases and then didn't tell how the votes went because they knew it was a political death blow for anybody. But that was how we, like, after the Cold War, ramped down our military presence, particularly throughout the U.S., when we didn't really need it as much. Similarly, barring something like that for hospitals, where we're picking and choosing which hospitals close, we should be reorienting. And again, this is Jackson talking. This is not Paragon talking. We should be reorienting our federal and state policy to enabling hospitals in rural areas to transition to something smaller, to right size for those areas. So that
what does that look like? So when you say that, okay, we've done episodes in the past where we've touched upon not you and I, but DC EKG has touched upon certificate of need laws, con laws, which prevent competition. Now you're talking about something else. You've got a big, and actually the Wall Street Journal has written on this. They had an article about some of these huge sprawling hospitals that are basically empty.
Yeah.
They don't have enough beds, but you're talking about something different, which is, let's take a hypothetical big hospital somewhere that was built 70 years ago, has been updated, whatever, economic dislocation. It's not seeing the level of services and intensity that it once did. It's an expensive facility. You want to be able to take that facility and that system and where those patients would access that facility and do what to it?
Ideally, and this is what the REH program does, and there are probably a couple of different ways to do it. What I'd want to do is remove the pressure on, for example, having inpatient beds, having these kind of broad swath of services that frankly they can't provide, or that a lot of people in their community don't want to go to get.
Right.
I think part of how you do that is, one, we talk about con laws. certificate of need. You get rid of the barriers to competition so that it's other physicians will want to move in and it's actually profitable to go in rather than going, well, you have to compete with the county hospital that's never going, that doesn't have to worry about a budget because it's constantly getting fed subsidies. So make it easier to compete. That also means, and this is kind of one of those things where this is going to take a while. This is not a thing you could do in a year, and it's probably not a thing you could do in 5 years. Reforming our current hospital subsidy system, which is not a subsidy in the way that most people think subsidies work, which is you just give money to an entity in need. That would make way too much sense for how we do this for hospitals. Currently, there's a lot of different like add-on payments in Medicare for if you're like a rural facility, if you're a sole community hospital, critical access hospital.
You train medical students, supposedly, all that stuff.
Yeah, exactly. You get, the boosted GME payments, even though med students just like some of the problem is like a human factor in that. Kids don't want to go live in the middle of nowhere a lot of the times, particularly when they've just racked up a ton of med school debt. Separate issue. Don't want to distract. So you're getting all these add-on payments, for every different, if you're 15 miles out, you get this add-on payment. And if you're 20 miles out, and if you're 23.7 miles out, you get the third add-on payment. And then you get a rural floor in your Medicare payment so they can never dip below a certain amount, which, fun fact, brings down reimbursement for hospitals in urban areas that might actually need it more because they're seeing more patients. Instead of all of that, and all of those things, all those add-on payments, they have these negative side effects. We're getting like the Cleveland Clinic, which could not be in more downtown, more centrally located in the city of Cleveland, is now a rural referral center.
Yeah. That's insane.
And it gives it access to 340B subsidies. And so what you really get is most of these subsidies in the first place are going to large health systems that are just raking in cash.
So wait a second. So this is an important point. So we have a system set up that is paying hospitals. They make profits based upon the spread between the cost and the services. And we reimburse them a whole series of add-on payments, extra money based upon what the Borg back in Baltimore at CMS headquarters determines is worthwhile or not. And you're suggesting a different approach, which is to say, maybe we need a hospital at X location that can handle emergency services and can do open heart surgery and can do this and specialized things like that. And there would be a core set of serious things that it could do, but it wouldn't be as big. And then outside of it, maybe there's a series of clinics, and some of them would be specialty clinics. So certain cardiac activities maybe could take this one was another one in diabetes. Yeah,
you'd have a hub and spoke model. That is, I think, I don't know about the ideal. I think that's the better end goal than what we're currently doing, which is trying to float a major hospital in every single county in the country when we have limited resources. We have a ever increasing federal deficit that, fun fact, that bill will come due. And if you're worried about healthcare cuts with the OBBB, just wait till Medicare Trust Fund runs out. All right.
Well, they're just going to raise taxes. I mean, they'll raise taxes and they'll devalue the dollar. I mean, that's where this is headed.
I'm sure they'll devalue the dollar for sure. I have strong doubts they'll have the political backbone to raise taxes. No one likes tax cuts when they're all tax raises while they're also getting increased services.
Right. Although that works well in the states, don't forget. I mean, look, there's a lot of states with pretty high tax rates and that ram them through with this tax the rich rhetoric. I'm telling you this, young Padawan, because I've watched it over and over again. Great states without any income tax say we need one, and now Connecticut has got one of the highest tax rates, tax burdens in the country. And it doesn't improve services as much as they say. It does expand government, and it only creates an ever louder justification for increased taxes. I mean, that's just the way it is. Yeah. The higher the taxes are, the higher they're demanded to be.
I agree, but it also helps that we have the state and local tax deduction so that a great deal of people in blue states don't feel their taxes that are as high as they actually are because they're getting that money back from the feds, which is that's way out of my policy realm. It is a minor gripe I have. But back to the point, what I'd like is a system of a hub and spoke model and where subsidies are, instead of these add-on payments to whoever or on whatever given service or whatever we think we can like best finagle, it's a direct subsidy to who actually needs it. It's a subsidy to the hospitals that are actually struggling. The Cleveland Clinic should not be getting a dime of taxpayer money. It doesn't need it. It's a world-renowned institution. It makes a ton of money when the Saudis go there and they build a whole $10 billion wing just for themselves, right? Like, this is not an institution struggling for cash. Mayo Clinic's the same up in Minnesota. What I want is the subsidies going to the hospitals, the providers, more importantly, that actually need it.
Right. Well, that's an interesting. I hope that you can crank out a paper on this at some point, because I definitely do think the hospital system is in dramatic need of reformation and innovation, I should say, to come up with a new model to harness the technologies that have come online and the natures of the way modern people live. So we don't have a ton of time, but I want to touch upon this paper that you just published on prospective most favored nation. So as we're recording this, there's an increasing clamor that there's going to be announcements very shortly on drug companies coming in to announce deals with the Trump administration to agree to what was the letter that was sent out to 17 drug companies demanding a series of concessions, including on pricing. Now, when this letter was sent out last summer to the 17 companies about the most favored nation pricing and equalizing the pricing between the U.S. and other foreign countries and to bring drug prices down, there was a tremendous amount of wailing and gnashing of teeth about this. But you and some colleagues at Paragon have written a paper here.
I would like to give credit where credit's due to my colleagues Ryan Long and El Minarik, who worked very hard on this paper. I contributed the best that I could to this. We're Paragon's drug pricing crew, as it were, and Ryan helped spearhead this idea. The current situation for most favored nation pricing, what the administration has proposed, is what we would call a retrospective model. Essentially, they take the prices as they are in any given European country for current drugs and would have the U.S. in Medicaid and in Medicare pay those prices specifically, regardless of whether the contract's brand new or with the European country, or if it's 10 years old or whatever, or the drug's brand new or it's about to come out. However it may be, they're going to take whatever the current European price is. We argue in our paper that prospective MFN is a much better version of this. So what we would do for new drugs, and in theory, we don't get into this in the paper, but in theory, you could extend this to eventually new contracts for existing drugs. But for new drugs in our paper we talk about, we would ahead of time say, hey, we're going to do MFN for your future drugs. So when those drugs eventually come out and they start going out to the European market, now a note, the US usually gets drugs several months to a couple of years before Europe typically does.
Sure.
We pay more for them, so we get them first. But when they do eventually go to the European market, the drug companies now have a very clear understanding that, hey, if you don't negotiate with these countries, and we suggest a certain subset of what we would call economically equivalent countries, roughly 90%-ish of the US GDP, with an equalizing factor in there, like Germany, France, England, etc. We're not including Croatia in there, for example. Nothing against the Croats, but countries that can afford to pay higher prices. And so we look at, hey, just know when you negotiate with these countries, that's going to factor into your average. We're going to average those together, and that's going to factor in your drug pricing. So if you think, oh, well, I don't want the U.S. price to meet that, then you should be negotiating higher. It gives a clear incentive to pharmaceutical companies, hey, you are going to lose money in the U.S. if you don't negotiate a lot better. It also sends a clear signal to Europe, oh no, seriously, pharma now has a real incentive to pull out of your country and tell you, no, actually, we're not going to just accept these low prices just because that's how we've been doing things. In discussions with various pharmaceutical executives, we understand that their markets they look at are the US, Asia, and then Europe is kind of just gravy on top, but it's not a serious part of their revenue expectations. They like making money from that, but it's not something they push particularly hard to make money on. They've had these deals for a long time. Some of the pharma reps that I've talked to have said, well, hey, it's really bad press if we don't have access to this drug in this country. There have been threats, of course. Oh, well, they're going to seize our IP and just make it themselves. Those are questionable, but that does mean the U.S. should be clear in a prospective MFN situation. We will be protecting our company's IP. Do not go in and seize them for various whatever made-up emergencies you're causing for that. So that does require the U.S. having a strong hand on IP there. But the prospective system gives a clear incentive to pharmaceutical manufacturers to actually negotiate with European partners and not just accept the price they're given, and to have real consequences if they don't decide, you know what, actually, we're not going to sell to France. I'm not letting them pay 1 penny for Humira, right?
Right. Well, I mean, that's the thing. I mean, look, the British have announced they're inclined to spend maybe 25% more on drugs, but of course they haven't put that in the budget. So color me a little skeptical that the end result of this is going to result in Europeans paying more. I think it's going to lead to a lot of companies, for the time being anyway, perhaps saying we're pulling out of the European market. I mean, all these policy initiatives, they always have unintended consequences. I don't think many people in the Trump administration, and I'm not sure the president cares if they pull out of the European market, but that will have a policy effect down the road. What the Europeans do, I don't know, but how the companies react, what their government affairs strategy is, how they engage with the Hill, what the Democrats do, what the Republicans do, all remains to be seen. But I just think the marginal increase overseas, if what you're proposing was implemented, and by the way, prospective MFN is a much better public policy solution than retrospective MFN, where you're basically punishing companies for having an expectation interest, which has been the way business has been done, for decades between the U.S. and Europe. And President Trump is the first president to really care. So I thought it was a great paper. I actually think, things are going to move in that direction. We'll see how this is played out. There'll be I think these demonstration projects are demonstration efforts. I guess they are demonstration projects out of the Center for Medicare and Medicaid Innovation will probably pop out relatively soon. And they're going to interact with these voluntary agreements. Maybe the companies will be exempted. We'll see how that's effectuated legally. But ultimately, I do think that the prospective MFN thing is where we're headed in the short term.
I certainly hope so. I agree with you. I think MFN is an IPI, International Pricing Index, which is the less severe version of MFN. Both of these are not free market policies. I do think they're importing foreign price controls. However, if the administration does seem very dead set on doing an MFN policy, so if they're going to do it, prospective MFN mitigates a lot of the issues that retrospective MFN has, where there's an immediate price cut to existing drugs. Prospective MFN says, here's your incentive to go forward and actually negotiate. Best of luck to you. So if we're going to do it prospectively. Give our drug companies, who are the basket, the cornucopia of innovation, that is one of the things that America leads best on, is our biopharmaceutical sector. Give those companies a chance at the very least, rather than immediately going, we're cutting all of your prices right now. Sorry if you had long-term plans. Too bad if you were working on a cancer drug, that's gone now. Don't sacrifice innovation for the immediate effect. Give them that chance. Mitigate these issues with retrospective MFN. Use that prospective MFN. Europe pays more. U.S. pays maybe a little bit less in the long run. I do think there's definitely a chance they pull out of a lot of European markets if the prices aren't right at first. That's kind of the point of this, is like, hey, Europe needs to stop free riding on what we've been doing, the money we've been pouring in through both our patients, our tax dollars, research budgets at our academic institutions, as well as our companies here. But pouring in innovation. Europe has been free riding off of that for a long time. If they don't want to pay their fair share, they don't get access. I don't have a strong problem with that. I think they will come around. Ultimately, the drug makers have the drugs, and Europe needs the drugs.
All right. So last question, 2026, are you optimistic or pessimistic about healthcare policy?
Optimistic. I remain ever optimistic I think in part the
Gotta
work.
be. Right answer.
Gotta be.
The trend lines are terrible, but otherwise,
Yeah.
what we should be, you got to quit and go back to criminal justice or whatever you originally cared about.
Exactly. And I think the work we do in 2026 sets up the future just as well, even if the legislation doesn't pass the way we want it to.
All right. Okay. Well, Jackson, thanks so much for joining. I've wanted to have you on for a long time. We've had scheduling issues. We've had technical issues. We've had all sorts of complicating factors, but thank you for coming on and for all the work that you do.
All right. Thank you, Jeff. Appreciate it.
I want to thank our sponsor, Survivors for Solutions, our producer, John C.Z. Swartacki, and all the people who help make DC EKG available to our listeners. Thanks so much.